I'm Dr. Neil Skolnick, and today we're going to talk about the 2020 American College of Rheumatology Guidelines on the Management of Gout. Let me start with a summary, which is very simply, allopurinol is a first-line agent and use a treat-to-target approach. Let's now go over the details. Urate-lowering therapy, with the first-line agent being allopurinol, is strongly recommended for patients who have had 2 or more gout flares a year, 1 or more tophi, or evidence of X-ray damage from gout in their joints. We can consider treatment for patients with less severe gout, but of course the benefit is not going to be as great if the disease is less severe. The guidelines suggest not starting therapy after a first episode of gout, though we might consider it in patients with CKD stage 3 or greater, or uric acid levels that are particularly high, greater than 9, because those things increase the likelihood that there'll be future episodes. In addition, we might consider urate-lowering therapy in patients who also have kidney stones. We shouldn't be using urate-lowering therapy in patients with asymptomatic hyperuricemia. In addition, the guidelines state that Probenicid, which is a medicine that used to be used a fair amount, is now relegated to add-on therapy in individuals who don't reach their uric acid goal using urate-lowering therapy. Let's now talk about some specifics of urate-lowering therapy. First-line agent, allopurinol. Next, we used to think that you needed to wait a while after a gouty attack to start prophylactic therapy because of fear of provoking an attack in proximity with the first attack. That's no longer the case. The guidelines clearly recommend starting prophylactic therapy at the time of a gouty attack. Before starting prophylactic therapy, though, one should consider checking for HLA-B5801 in individuals of Southeast Asian descent or in African American patients, because the prevalence of that allele is respectively 7% and 4%, and its presence increases the risk of an allopurinol hypersensitivity reaction. What dose should we start at? Well, it's recommended that we start at low-dose allopurinol in order to decrease the likelihood of a hypersensitivity reaction and in order to decrease the likelihood of a flare. What is that dose? 100 milligrams daily for most people. You can start with less in those with chronic kidney disease. Since we know that when we start prophylactic therapy, there is an increased risk of provoking a flare. It's also recommended that we start anti-inflammatory therapy with either colchicine, NSAIDs, or steroids at the same time as starting prophylactic therapy, and that we continue the anti-inflammatory therapy, which is prophylactic in this case, for 3 to 6 months. Additional things we might consider in order to decrease the risk of future attacks include limiting alcohol intake, limiting purine intake, and limiting the intake of high fructose corn syrup. In addition, if someone is overweight, for this and other reasons, we might discuss weight loss. Now, a key recommendation in these guidelines is that we should use a treat-to-target approach. What that means is that we should start with low-dose allopurinol and then recheck a uric acid level. If the uric acid level has not gotten to below a level of 6, then we should increase the dose, and we should incrementally continue doing so until we reach a maximum dose of allopurinol. Now let's switch to acute management. Here, we're not going to spend a lot of time because the guidelines have now changed, and I think we're pretty familiar with it. Anti-inflammatory agents, either colchicine, NSAIDs, or steroids. So, to recap, start with allopurinol, use a treat-to-target approach with a target uric acid level of 6 or lower, and then for acute flares, use either colchicine, NSAIDs, or steroids. I'm Dr. Neil Skolnick, and this is Medscape.